Alrighty, thank you all so much for coming to our first SLAM surgery session. We want to have a big warm welcome to Dr. Schnack for coming out here. So can we just have a nice
guys. Well, thank you.
She's the clinical advisor for our club and is a powerhouse here at Shoal. You may have had her teach your classes so far, maybe not, but you're in for a treat. She's fantastic. And the whole point of starting these sessions is that not only do we get to learn more about physicians in our area and our field, but we get to hear more about their background, what brought them here, the challenges that they faced, kind of getting us ready for the real world once we leave outside of here. So without further ado, this is Dr. Schnack.
Guys, thanks for having me. Do you want me to wear this?
Yeah.
Sure, yeah.
You wear that.
Well, thanks for having me. So sweet of you guys to include me.
I'm going to have you actually introduce yourself. Tell us
Sure.
a little bit more of your background.
Sure. So I'm Dr. Lauren Schnack. I was born in the Cleveland, Ohio area. I went to Wright State University for my undergrad in Dayton, Ohio. Studied anthropology and health sciences. And then I went to Case Western Reserve in Cleveland for my master's in medical physiology. Went to Kent State College of Podiatric Medicine for my DPM degree. And then went to St. Vincent Charity Medical Center in Cleveland for residency. It was the old Gerard U program, which is now closed, unfortunately. And then I moved to Chicago to do my fellowship under Dr. Edgardo Rodriguez, who is also here now. We just couldn't be apart. Yes. And so he is the director of recruitment strategies here. And so I did my fellowship under him it was Amita Health St. Joseph Hospital, Chicago, but now it's under Ascension. It was Presence before, so it keeps changing names if you ever look up the history, and it gets confusing. But then him and I worked on a research project here, and then that's how I interviewed and was hired here, and life has never been better, and I love it here. It's great. Shoal has a really, what I like about this university, you guys have on-campus housing available, so if you want to take advantage, great. If you don't have to, so I like that option for you guys. And then also the research, another option. You don't have to take advantage, but it's just something else I think that this school brings to the table for students, among other things, of course.
Well, that is really great.
Yeah.
So to kind of get us started, we were kind of curious what kind of brought you into the field of podiatry, and then specifically why a fellowship in microsurgery and arthroplasty?
Right. So I fractured one of my metatarsals just playing basketball. It wasn't a big deal. I didn't have to have surgery. My mom actually fractured she had a Liz Frank fracture dislocation, so she had to have two surgeries, the open reduction, internal fixation, and then the hardware removal. And so she dislocated her midfoot. I was like, wow, you go to a DPM, what do? They do wound care, they do surgery, they do all these things, sports medicine. And then I thought, okay, I knew I wanted to go into medicine, but then realizing podiatry has so many facets. And then also with my background, anthropology, and I like birds, and then the bipedalism, you know what I mean? Of the evolution of how we came to walk, and gait analysis was also interesting. So I was like, oh, okay, this makes sense. And then finding out you can do other things. You can do orthoplastics, microsurgery, and basically I'm going to tell you guys what I tell the students or prospective students that I interview is that a lot of people think that podiatry is limited because it's it's only lower extremity or it's foot and ankle. Well, I see it the opposite way. I think we're less limited because we can do more. So you have your vascular surgeon does veins and arteries, and then you have your plastic surgeon that just does soft tissue, and then you have your orthopedic surgeon that just does bone and joint. But we can do all of those things within reason to the foot and ankle. Vascular, we're not going to do complete vascular repairs, right? You shouldn't, but but there's other things that we're so dispersed and intertwined and interprofessional with other specialties that it really makes podiatry limitless, right? So I always say to prospective students, we can kind of cross over to plastic surgery and orthopedic surgery where they can't. Orthopedic surgeons can't do flaps and things like that, and plastic surgery can't do bone and joint surgery. So to answer your other question, micronerve surgery is like we can do more than just bone and joint surgery. These patients need, other techniques. They need external fixation, which surprisingly a lot of orthopedic surgeons don't do. So that's more of like a podiatry thing. Thinking that, okay, well, what type of patients are out there in podiatry? They need diabetic limb salvage. Maybe they need a flap or a nerve repair for chronic pain because they have a postoperative complication, and then to be able to address those things is why I got into the fellowship, is because I'm like, wow, there's a need for it, and I want to be in this niche. Like, I want to be able to be an asset somewhere, wherever I get a job or whatever I do, because I want to be able to bring a different aspect to the table and be unique. So I think a lot of our patients need someone who can address chronic pain, or just at least show them a doorway to, hey, you need a nerve conduction study, go see this person. Or maybe you have a nerve issue, instead of saying, oh, well, no, that's okay, you'll get better with physical therapy. Maybe they won't. So I think it's just broadening my education was why I went into the fellowship, because then I can just give my patients more treatment options. If that makes sense. It's a long answer, but
it's a great answer. No, that's really great.
Yeah. And so the second question, kind of going on that as well, what challenges would you say that you faced post-residency becoming a physician?
Post-residency or post-fellowship?
Post-fellowship and residency.
I would say it's just a different way of living. You're always going to want to learn, right? So AACFAS says forever or lifetime learners, or whatever their motto is. And it's true. So I think you still want to learn, but then you have to do a job too. So I think in training, everyone should just be totally focused on learning as much as they can. You should still do that when you're out in practice. But then now you're the one making decisions. So then you're thinking, okay, am I making the right decisions? Wait, let me look that up in evidence-based medicine. Let me make sure that what I'm doing, I'm not going to second guess it, because these patients, need answers, they want explanations. So I think just making that transition of now you're responsible is just, it's interesting for everybody. I don't want to say it's not difficult, it's exciting, but it's oh wow, I really got to make sure that these notes are really, really looking good, because it's my medical license on the line. Yeah. That sort of thing.
Yeah.
Okay. That's wonderful. So, kind of going off of that, what kind of personal hurdles have you faced while being in school, and then post, and then residency and then fellowship? How does personal life look like during that time?
So it definitely, I think it suffers. There's so many things that I feel I missed because of I have to be in town just in case more consults come in during residency, or I have an exam and I need to study and I can't go to that event or things like that. So I think with every sacrifice, if you make good time of why you're sacrificing that, you can get to the next level, and then you can at least know that hey, I didn't go to that party, I studied for that test, and yeah, if I get an A on it, great. But if I get a C on it, well, at least I tried and I did all that I could to be successful. So I think there's a lot of sacrificing, and that's where it becomes difficult. So sometimes you might lose some friendships, but and that's tough too, because maybe you don't keep in touch with everybody that you wanted to, but again, you still need that time to yourself to have your you time and enjoy life and be yourself. But it is a big sacrifice if you make the proper time commitment to study and succeed. And in training too, like I said, a lot of vacation days are limited sometimes in residencies, and then you just want to make most of the time that you have with the patients, because those aren't your patients. They're other attendings' patients. So you're okay, not that you want to mess up there, don't do, but this is your time to learn, because then you'll be on your own. So you want to take full advantage of that time. Mm-hmm. So then it's tough, it's a lot of time after hours even. Mm-hmm. Yeah.
So almost what was your longest day? What did it kind of look like?
I mean, sleeping in the hospital, if you call it sleeping, I just, my longest day. Oh gosh.
You're kind of just
the war flashbacks.
I think there was one period of time where I don't think I slept for like 40 hours. I think it was just like, and then like we were doing like emergency surgery and things. And then it was like, before that I had like 3 hours. And then like, before that I had 3 hours of sleep. And it just, yeah.
So is that what residency was like? Or is that like fellowship? Like
that was more like residency. Sometimes fellowship, but like mostly residency.
Okay.
Yeah.
No, that's so interesting.
Yeah.
Can't wait.
Can't wait.
Well, that program closed, so it's okay. I mean, because of funding. It was like funding. It was a great program, but the funding just wasn't there. So that's why I closed. But it was a great program. I'm glad I went there. Yeah. Great training. Yeah.
Yeah. Well, I'm sorry that you lost like friends along the way, but like.
Well, it's not like that. Like, you know, but yeah, you lose contact. Yeah.
Yeah,
It's,
well,
it's their fault. It's not mine.
Well, I was going to say people that like, you know, should understand what you're going through and like there's sacrifices that you have to make, and at the end of the day, like you are where you are now because you've made those sacrifices, you've done those things.
Yeah, that's the way.
And kind of like going on those sacrifices, like you have accomplished so much since residency and since fellowship. Like, well, you just recently completed your fellowship, and that means that only 2 years, and you've already published how many papers? Like so many. Yeah. And you continue to publish papers and to like really put your all in like research, as well as being like teaching us and like, you know, like allowing us to learn through you. And I just want to not understand, but like know how you have that motivation and keep that motivation to do that.
Well, thank you. Well, I love what I do. I absolutely love it because of the diversity that we have. Like we can do bone and joint, we can do nerve, we can do orthoplastics. So I think just if you love what you do, it's not like really work. But I will say that these research papers, I'm looking at you, they get done you know, there's like little bits and pieces of time that I have during the day, like in between, but not typically, but they get done. So I'm just telling you guys, if you guys are interested in research, which I highly recommend because it will help your CV tremendously, and this is one of the reasons why I got the fellowship, is like a lot of it's like after hours, Friday, Saturday nights, if you're not busy. And like, but I love it. So I'm like, okay, like I'm going to get a jump on this because, so then what I like to do is then you can take that and then you can put it in a presentation. And then like I can go to a conference and say like, look at what we're doing at Scholl. Like we're doing the sterile nerve variation research. Like we did this reset neurotomy, and then like I can use it for multiple things. And so it's not just like one paper. It's like I could teach you guys, or I could use it again, or I could teach other physicians. And so I feel like it's useful, and it's, I don't know, that just motivates me, you know, and then it's good for networking. So then they're like, oh, like, what are you doing with that, like, reset neurotomy? Like, let me ask you. And then you meet new people. So I think, like, that just keeps me going. It's just, like, that interest, and then just kind of, like, sharing the knowledge. And then, like I said, you can add that to your CV, and it can help you get, like, a fellowship or a residency. So just keep it in mind.
I guess bouncing off of that, you know, I've read a few of your papers, and especially over the summer. Well, especially over the summer, you actually showed me some of your work, and it was so exciting to read it. And then, you know, a question I kept like going through my mind is like, how do you kind of come up with these new like surgical techniques, or are they new, or are you just like reinventing the wheel? Like, how do you kind of get your like foot rolling or get started on writing these new papers? Like, what crosses your mind, I guess?
I think, well, it depends. I think like a lot of it's mentors. So I had some really great mentors. So one of them was in my residency. So I think you guys had talked about like the hallux IBJ arthroplasty. I think was one of them. Yeah. So the hallux interphalangeal joint arthroplasty was the one that one of my mentors had come up with, and then he's like, well, they're doing this like dorsal approach, and they're going through the EHL, and that's like really destructive. Like we could go medial, and then they could weight bear immediately and have like less complications, and it's offloading it intrinsically. Let's do this. So he like came up with it, but then we were like, okay, like let's do resident research day, let's do all this stuff, and it was successful. Like we won, and then we published it, and then it was just nice because then I can do that with my patients, and I can say, Mrs. Jones, look, like we published this, and they would be like, oh, okay, like sure, let's do that procedure. Not that I'm trying to convince anybody to do surgery, but it's like, you know, it's I think it like reassures the patient too. And then like Dr. Rodriguez, like he's a powerhouse in just coming up with new techniques and everything. So just kind of seeing like what he's doing and okay, like how can we keep that momentum going, and is there something that we haven't investigated yet, or like we're going to look at the saphenous nerve, hopefully right
funding,
exactly. So stuff like that, and it's like, okay, well, what else can we do, and because it does like take a village sometimes, so it's like takes like a team to and it takes it helps when you have great mentors and great support. So I think that like also is helpful. Keeps us going.
Oh, that's really great.
Yeah.
But so like I guess specifically though, like when your mentors are even coming up with like new techniques, what kind of background stuff do they need to do so that they can start doing these techniques? Is it just something that you put in a informed consent that you tell your patient, hey, I want to do this, or like kind of like what kind of goes on into in that process? Yeah.
So you don't want to do anything out of what's the word? Standard of care.
Yeah.
So you look at previous literature, you say, okay, like what's been published before, what's appropriate, could anything go like terribly wrong? And it's not like you're doing anything crazy, like, instead of going dorsally, we went medially for that one procedure, or, the reset neurotomy paper we did was off of the reset neurectomy. And it's funny because like we called it the reset neurectomy, but one of the reviewers at the journal was like, well, isn't this like really a neurotomy? And then so like that took off. So it wasn't, So there's other published things that you kind of go off of. So the people before you, you look and see what they did and just read, and then think, okay, how can I use this and like utilize this in my practice, and then, make patients have better outcomes, So it's not like you're doing anything rogue. It's just like, me being like a newer practitioner, I like to see other people do stuff and then I'll do it. Like until I get to be like at Dr. Rodriguez's point, then maybe I'll do some like more interesting things. But yeah, I mean, like not that I don't do interesting things now, but like, he's the one that's like first to do this. And so maybe in like a couple of years, but yeah, I like to like look at the literature first, and so does he. But
no, it's always so interesting. I always like read papers, and I'm always just questioning. I was like, how did they like kind of go about this approach, this approach? No, that makes a lot of sense.
And a lot of papers are from. I mean, if you keep doing a deep dive, you'll see the references and where they got their ideas. So typically, they'll, it's I don't want to say like a spin-off of another paper, but there's like a different angle to it. So like there's another fibular fracture paper that one of my mentors and I published, and it's like a rod, which we went over in P2 workshop last year. No, you guys. Oh no, we'll go over it. You guys know P3s aren't here. It'll be fun. But there's other articles that'll say, oh, rush rods could be used instead of the rod we used, or things. So yeah, there's always like some related literature that you can use to back up your, your paper or manuscript.
Oh, that's great.
Yeah.
Thank you.
So, kind of switching gears just a tiny bit. I was just curious as to what do you think is like the most misunderstood thing about the field of podiatry?
That it's limited, which it's not. I don't feel like it is. We have so many bones and joints and ligaments and tendons and insertions and everything in the foot and ankle that all these things go wrong. And then you look at the knee joint, which is like really interesting, but it's just bigger. It's like, oh, well, like there's less bones there. You know what I mean? And it's like, well, like what could go wrong with the knee joint? A lot, but look at the foot. Like look at how many foot joints and bones there are. So I just think there's a lot of pathology that can go wrong, obviously, because there's so many structures, and then we really need to be the specialists and know how to treat it. And I think it's one of the most complicating, I shouldn't say, I would say challenging professions because of that. But I think people are just like, you clip toenails. Well, no. I mean, like that patient that you're clipping toenails on could have like a Charcot rocker bottom foot that can ulcerate and have all sorts of problems, and then they can end up having an amputation. So really, like, a lot of education and background and reading goes into this, before you get out into practice, because there's so many, we deal with the sickest of the sick patients, and I think people don't understand that. And it's, we'll teach you all about it here, but it's, I think there's a misconception, and then we're trying to change that. You know, I know like Dr. Rodriguez and Dr. Saeed are going out there and just educating everybody and saying like, hey, like this is what we're doing. As you know, we're doing fractures, we're doing not just toenails. Like Rodriguez probably hasn't seen a toenail in like 20 years. I'm just kidding. But you know what I'm saying? Like he does, like, you know, you can specialize like him and make that your own practice. Or if you want to do toenails and palliative care, that's fine too. But I just think that there's just a misunderstanding. So we're trying to get better communication to the colleges and the public so that they know that we do more than just that. We do fractures, we do everything, foot and ankle.
Even pediatrics.
Pediatrics, sports medicine, diabetic foot care, wounds, everything.
Geriatrics. the whole spectrum.
Yes, everything.
Oh, that's really great. So I guess a little bit more into that. The type of patients you see, are these like type of patients that know what a podiatrist even is, or are you like their first podiatrist, or do you kind of get a range of, how do you basically get your patients? How do they find you?
I find them usually at Vista Medical Center East, or they might get referrals too. They'll might like, so some nerve patients were referred to me from. It was funny, from a doctor out in Rockford who I've never met her, Dr. Kelly John. She saw one of my lectures at Midwest Podiatry Conference and had a bunch of nerve patients and then referred them to me. And then it's funny because then she went to go work at Des Moines. Isn't that funny?
Yeah.
Yeah. So it's that. So like just word of mouth, or I just get calls from Vista and then I'm like, oh, that looks interesting. I'll take that on. Oh, you have an ankle fracture? You have an abscess of your ankle? Like you need an X-fix or something? Like, and then I go over there and then I'm like, here's my card, here's my information. You need to follow up with me post-operatively. And then they come over here and then you guys get to see them. Yeah.
Love that.
Yeah. So I'm trying to draw on that surgical pathology from there. But we still get good pathology that walks through the door. I mean, there's like bunions, hammer toes, like some Charcot feet that just like maybe have pre-ulcerative lesions but don't have like open wounds, or so we do get, you know, if you look at it with like a certain lens, like you see a lot of surgical pathology over there next door.
Yeah. Very interesting. All right, so we have to know the birds. Where did they come from? Where's the passion from? Like, we know you've alluded to it a little bit earlier, but where did it actually kind of come from?
I think I had from the beginning, I had like fish and frogs growing up, and then like I would catch them in like a pond that we lived by, and then we were getting food for frogs, and there was like this, like the cutest bird at this aquaculture pet store, and I was like, oh my gosh, like it was adorable. And so he was an Indian ringneck parakeet, and he was amazing. He was like the nicest bird ever. And then, long story short, we had a death in the family, our patterns changed, and then he started picking his feathers. So my brother and I were little, we were in elementary school, we went back to school, like nobody was home, like a lot of things had changed, and then like our patterns got normal again, but he like still was picking his feathers. It was like a bad habit. It's like the vet said, oh, it's when, you know, someone goes through a traumatic experience or something bad happens, someone starts biting their fingernails, and then that worry is over, but then they have this bad habit. So this is what happened to our bird. And we're like, we tried everything. We're like, come on, stop picking your feathers. And he used to be like bashful about it. He would like pick his feathers, and then like we'd walk by and he'd stop, and then like we'd, you know, be out of the room, and then he'd start picking at his feathers again. But so he passed away. And then, but he was wonderful. And then there was a rescue bird that was available like months and months after he had passed away. And she already like was a feather picker. And so she was a Quaker parrot, and she was already 2 years old, and she needed a home. So we're like, okay, like we have a cage, like we can rescue her. And I mean, they look like freezer chickens. They look like completely ridiculous. And she was like she had such an attitude problem, but she was so fun. Like she was so fun. But she was really great. And then she passed away. And then, because we're like, well, we had a feather picker before. Like we're gonna, you know, no one's gonna want a feather picker. They want their plumage. They're usually bred for their color because they were both bluebirds.
Wow.
So like, they're not as hardy, they're not as like strong, or they're more susceptible to things, is what I was told by the vet. But so they were both blue, and they were great. But then she passed away. She was like 12 years old. She almost made it to 13, which is pretty good. Like for these types of birds, say they can live longer, but like with all her health issues and everything, like, and then my brother got another Indian ringneck, and she's so cute. She's like white, and she's just, yeah, she's friendly. But yeah, so I highly recommend birds. And I think I'm going to get a bird now for P2 workshop, because I keep repeating myself, not her. This, she understands me the first time. But yeah, I think because yes, you guys know. Yeah. And then the bird can just teach the class, and I can just, like the bird will just already know all the words. Assessment and plan. Yeah, assessment and plan. At least the bird will listen.
Yeah,
exactly. Yeah, at least the bird will listen. Yeah, exactly. Yeah, but no, they're fun. Like they can, because they're so smart and they're so social, so they get like emotional and like, or they'll attack people, and I'm like, why are you attacking her? Like, she just gave you a treat. And so it's really interesting, because a lot of people think, oh, they're just like the birds outside, but they're domesticated, so they have these little personalities, and like they'll pick up words, like they'll pick up things, and or they'll play peekaboo and everything, and they're just a lot of fun. So people don't understand. They're like, well, I'm a dog person, and I'm like, well, have you been exposed to a bird? But they need a lot of attention. Mm-hmm. They're like, it's like some of them are like a 45-year commitment or longer, and people have to will them, because some of them live so long. Yeah, like the bigger macaws or cockatoos. Okay. Yeah, but
learn so much.
It's a big commitment. Yeah.
Well, that is really great. Thank you so much for answering all these questions.
Of course.
We did want to open the floor, though, to anybody who has questions in the audience. This is a great opportunity to ask Dr. Schnack. So if you do have any questions, please just raise your hand. We'll call on you. Ooh. All right, we'll start with Anna.
Hi, thanks for being here today.
Of course, thanks for coming.
Yeah, I was wondering, like, for us P1s who are just starting out, like, how would you encourage us to, like, find out if we want to specialize, like, to go and explore, like, how early is too early or not early enough, like, to go and test out which specialty you want to go into?
Yeah, I would say, it's never too early. How should I say? I would try to, it's not necessarily specializing, it's just like trying to do everything, right? But if you have an interest, then like microsurgery is very specialized, or external fixation. You might have like a program that does external fixation, but like not a lot, maybe more internal fixation for a residency. Then, maybe you could think, oh, maybe I should do a fellowship that's external fixation focused or limb salvage focused. But I never think it's too early. And then just, if you guys have questions, if you guys want to shadow somebody outside of Rosalind Franklin, I could put you in touch with people. Or if you're interested in like certain residency programs that do certain things over others, trying to like network with as many people as possible, because because there's so many residency programs that maybe like, oh, you're interested in like XFIX and limb salvage, maybe go to Seattle or go to Lima, Ohio, or oh, you're interested in muscle flaps, maybe Cincinnati would be a good one for you, or that sort of thing. But I can, because it is overwhelming. You're like, what's out there? Where are residency programs? What do I do? How do I find them? Just think about what your interests are, and just kind of like, you can read articles a little bit, and where are those authors from? Are they DPMs? And then think about like, oh, do I want to maybe think about externships and residency as a location? Like, I want to stay here, I want to go to Wisconsin or Florida, and then maybe, is that important to you? Like, also looking at what's important to you, and then where you want to end up, and then I think you can find like a good program with your interests that you can grow in. Does that make sense?
Yeah.
So I think just finding out, like shadowing, reading articles, and then just talking to people, like just seeing like what's out there.
So sorry, again, then a follow-up question. So how did you decide your residency? What was like your defining moment? Like, okay, yes, I want to go into residency in orthoplasty.
So my residency actually didn't do orthoplastics or nerve, because it's newer. So when I was at Kent State, like I heard about Dr. Rodriguez and I was like, oh, he's awesome. Like I heard great things. And then I like went to residency. It was mostly like orthopedic type procedures. And so I always heard about the orthoplastics and like muscle flaps and the nerve. And well, the nerve was like coming to fruition because now Dr. Rodriguez mostly does nerve. But I was like, oh my gosh, that is so cool. Like I didn't even think coming into this, you know, years ago that we could do stuff like that, but now people are doing it. So I always had an interest in it. And then Dr. Rodriguez came into town for a lab in our, like for our, you know, for Cleveland. And I went and I'm like, oh my gosh, this is so cool. And he goes, yeah, I have a fellowship. Like, let's keep in touch. I was like, yes, I'm keeping in touch for sure. And then I emailed him and I was like, hey, like, can I come visit? Like, can I interview? Blah, blah, blah. And then like, so just networking and talking to people and just, I think it's just like whatever interests you, you know, like some people like sports medicine and then, you know, they could do a sports medicine fellowship or you don't even have to do a fellowship, really. You could just, you know, if you get a good job out of residency, like, or if your residency is like, hey, you know, like I feel like I covered everything here. I feel like I don't, you know, necessarily like need that extra training or want it. Like, that's okay too.
Thank you.
I know it's a long answer. Sorry. I hope I answered your question. I feel like I danced around it. Are you sure?
Yeah.
Okay.
Yeah.
Alrighty, any other questions? I know we had a few other hands. Monica?
Did anyone else want to go first? Okay, so I guess my question was, being a female in this field, what were some of the challenges that you faced to get to where you are today, and how did you overcome them? Because like obviously you worked very hard to get to where you are right now, but did you face anything that you felt like you had to fight for your position or you had to really prove yourself?
No. See, like I get asked that a lot and I feel like no. I know that's like a surprising answer, but I don't feel like I was treated differently as a female. I'm trying to think, how should I answer this?
It's not surprising, it's refreshing.
Yeah, I don't
really
feel like I
refreshing.
was. But so my residency program, I will say this, my residency program, my grandfather had died at that hospital like years ago, like when I was 8 years old. So I already had like a rapport with that place, like not with the people, but like I was just familiar like with that hospital. Like I'd been there 100 times, like visiting him. And so like actually my whole maternal family actually passed away there, interestingly enough. And then I was like, oh gosh, like, but they have a great training program there. And I was like, you know what, this is what I want. Like I'll just train there. So I felt that like I may have gotten treated differently for that in like a negative way because I had, which should have, I feel like, been treated better. Does that make sense? So it wasn't female male related, but I think just like talking to people and you know, like being friendly with everybody and like, you know, not being cliquey and just, you know, like getting along with like males, females, nurses, attendings, you know, physical therapists, and you know, just is really important. But yeah, I don't think I don't think I've been singled out because of being a female.
That's good to hear.
Yeah.
Really
I'm trying to think, like, I don't know how else to like put it, but yeah.
That's great. Sometimes
You know what I mean? Like, but because my
that's a beautiful thing.
yeah, but because like I knew I was like more familiar with the hospital. I don't think people like that. But like, I'm like, I just want to be treated like everybody else. you know what I mean? Yeah. So, because I was there before everyone, and so you know, I was like, I was here when I was 8 years old. Like I was here before Dr. You. Like I was, you know what I mean? But I didn't like come in the door like that. I was like, oh, like I love this place, and I think people just like different personalities don't perceive things the same way, and so that's another thing when you guys are out on externships, like, you know, like we talked about today. So like, you know, if you're always ask questions, but some people, like, you could be the nicest person, but they just don't like what you're saying for whatever reason. They, you know, like you might ask a question, but you know, it's maybe how you ask a question or how you know, like, oh, for my own education, like, I'm just wondering why we're doing this procedure instead of like, why are we doing this procedure? You know what I mean? Like, it's, I think, but, you know, yeah. Yeah, sure.
How did you make yourself like stand out at all these like extra shows?
Just doing what you're supposed to be doing. Just showing up before, you know, on time or early, just being prepared. I don't think I told this group these stories yet. This is a fresh group. So yeah, so I was in an externship after interviews, after boards, and it was February. It was like a month where I'm like, I don't, you know, it's like anything happens. I actually roomed with a Shoal student who was she was a Shoal graduate at that point. She was a third-year resident. But I was like, well, like, even though I'm like rooming with like one of the residents, I still have to be on my best behavior, like, you know, and all this stuff. And we would even drive separately, like, because I needed to get there sooner. I'm like, no, I'm going to get there early. I'm not even going to take advantage. She's getting there later than I am. I'm going to be there early. And I was externing with one of my classmates. This is at the Dayton VA. And the Dayton VA loves Shoal students, by the way. So this other Kent student that I was with, I'm like, what are you doing? And so it was 4:00, like, during the week. And the resident goes, well, you know, I think we're going to go maybe, like, do a consult. I think a consult's coming into the ER. You know, if you want to come down there, we can go work up the patient. And I said, okay, yeah, sure, yeah. It's 4:00. I'm like, if it was 8:00 at night, I would have done it. My classmate says, you know, I think I've had enough learning for today. I'm just going to head out. I'll see you tomorrow.
Cardinal sin.
And he got his book bag and his coat and he left. And I was shocked because he, like, would go to, like, this stuff. And then faculty and staff and students would say, like, don't do this, don't do that. And then he did it. And then I told the resident, I was like, listen to this. I said, like, and then I told her, and she goes, oh no. So she's like, what's his phone number? And I gave her his phone number. And she's like, hey, I'm Dr. So-and-so, program director. I want you to do a PowerPoint presentation on the etiology of Charcot neuroarthropathy and and all this stuff. And he's like, okay, yes, doctor. And then she lets 15 minutes go by and she goes, just kidding, this is Christine, I'm just messing with you, it's okay. And he goes, you're a monster. Like, don't say that stuff. Just don't do it. He called the resident a monster. I'm just saying.
I think lesson for us all, watch what you say.
He did not get his first program choice. I'm just saying, like, follow up on that. I'm like, oh God.
I guess a follow up on that. So is the world of podiatry as small as they say it is?
Yes. It really is. It really, really is. It's nice though, because it's like, oh, you know, like, so I was in Hawaii for a conference and I met a Shoal graduate, so that was nice.
Oh, that's
I was
great.
like, oh my gosh, like, you're doing this conference and you're a Shoal graduate, that's so great, you know what I mean? So it is nice. And then we talk about experiences and things and compare notes, and so definitely it's good to, like, watch, like, what you say and do.
That is great.
I was also I got another story. So I was visiting the program that I ended up doing residency at, and it was just like a busy Thursday surgery day, and this student, like, so it's 8:00 at night, 6 or 8:00 at night. It was later, and we were, like, in the middle of a surgery, like, everyone's scrubbed in. Too many people are scrubbed in, but it's a learning experience. And so the student, like, backs away from the surgical field and just rips her gown off. She goes, okay, what time should I be here tomorrow?
Bold.
Yes.
Bold. That is
like,
bold.
Oh, like, my husband's in town. I'm going to meet him for dinner. Like, what time should I be here tomorrow? I know.
I know not everybody on the recording can see this, but the amount of jaws dropped in this room just from that story alone.
Yeah. So just, like, that stuff, it's just, it's alarming.
Yeah, and, like, the thing is like, when you hear these stories, you're like, that'll never happen, because that's, like, so outrageous.
Yeah, but it does.
It happens.
It does.
It happens, and you'll see it, and just as long as you don't do it.
Well, that is great. Are there any more questions?
Yes.
Okay.
What made you want to go into academia versus, like, the traditional paths that, like, most UPMs
I love to talk, and you guys must listen. No, I'm kidding. So you'll see residencies are required to do academics, and I always saw value in that. And then, like research and all the things that are involved with academia, because I thought, like back in first grade, if you would have told me that I was going to be teaching, I would have said like, no way. Because you're like, oh, geez, when can I just go outside and play with my friends and not do homework? But, I mean, you realize the importance of education and academia. So I've been going to school forever, and then it's like, oh, you like learn to love it. You're like, you love what you do. But, when you're in residency and fellowship, things do become academic. And if you like that, and if you like going to the literature or doing research or teaching, because you'll be involved with like other residents, students that rotate through, and if you enjoy like helping and teaching and bridging like any learning gaps and helping them, with their knowledge base, then teaching's a great path for you, which I loved. I loved like working with students and externs and everything. And it was always a good experience. And then like it's great to be a part of a university. Like there's great resources. I love it. Public service loan forgiveness, if you guys are interested in that, good benefits. But I mean, it's really like you have to have a passion for teaching. I mean, which I do. I love it.
That is wonderful. Mm-hmm. Well, thank you so much
for
answering all of our lovely questions. We did talk to you about maybe possibly if you want to show us any techniques. There's no pressure to do so. That's if you want to. We can do that. Did you want to do on a suture pad?
Yeah, we can do it on a suture pad. That's fine.
So what we're going to do for this part...
can I use this as well?
Oh, yes, this is for you.
It's like, a 3-2-1 may be better. Okay. This, I might just.
Yeah.
Okay. So biggest thing too, say if this is your incision and you're, just
come.
Yeah, we can come.
Yeah.
Come.
Okay. How about we all go there?
Huddle here. We'll take a video. Just in case you missed any part.
And this is how you hold it, like I say, like tweezers. You hold they're not tweezers, they're forceps, but you hold the forceps or pickups like you would tweezers, right? So, but that's not the proper term. But when I say that, you guys know what I'm talking about. Hold the needle driver 1/3 of the way, right? So rule of halves, another principle. We teach principles, right? So say if this is your incision right here, you want to go and you want to at least start halfway through, right? So and then you want nice equal depth, equal bites. So like equal, so what I'm saying is equal here, equal depths, right? So I go over across the incision, right? Pull this through. Now, gathering, I think, is one of the most difficult things to learn. So hold my pickup in the palm of my hand, and I like to have control over it. Some people say, oh, you can just drop the needle like and gather the suture end on your own, and then there's no traction, then there's less of a risk of you stabbing yourself or somebody else. So, but I like to hold it and have control. So I like to hold it in my index finger and my thumb, and then so I'm pulling this through. So what I'm doing is, okay, so see how I'm situated here. It's like an accordion. I'm pulling this through with my needle driver, and I'm holding it like, this is hard on this pad here. I'm just like cutting it in half, right? And I'm pulling this through, and I'm just laying it in my hand, folding it and laying it there, okay? Then I can kind of pull this accordingly, adjust this, right? I say, okay, that's a good, I don't want to waste suture, so this is a good little tail I can have here. And then I like to do 1, 2, 3, and then cross your hand, lay it nice. So it looks like a little pretzel, right? So and then when we're learning, if you let this go, it oftentimes gets loose. So I like to lock it, okay? Then I let it go, and then I go back to uncross the other way, right? And then go back, 1, Cross your hands again. And that is a nice knot that's not loose.
Beautiful.
And then you just cut like a nice tail, not too long, not too short, and then here. So ringed instruments go in your thumb and your ringed finger. Right, so and then if you are the one removing this suture, then you can have something to grab onto and pick it up and then cut it underneath the knot, right? There you go, and the whole thing is removed.
All right.
Makes sense?
That does. Thank you.
You're welcome.
All right.
Yeah.
Well, we want to have a big round of applause for Dr. Schnack. Thank you so much for coming out.
Thanks for coming.
Thanks so much. We hope that you all enjoyed this session and hope you guys keep coming back for every month when we have new physicians kind of come out here. It might be in Zoom, it might be here in person, but we're always trying to make it as interactive as possible. So thank you all. Thank you.
Thank you. Thanks, guys.